Is there a mic or mic is not needed? No mic? Okay, no. Good morning, everyone. Thank you for having me. And hi. So it's like amazing that, it shows the power of youth and the power of groups so that you could get AO to listen to you, which is not an easy thing to do. So I have one question before we start. Which of you, raise your hands, do not speak German? Do not speak German. Okie doke. So now I want you to tell me what is the full form of AO. Okay. Does anyone know what is AO? You know, yes, of course. Yeah. Okay. No, you really don't know. Okay, it's Arbeitsgemeinschaft für Osteosynthesefragen. Luckily, I speak German. So, yeah. Basically, it means working group for questions related to osteosynthesis. Very simple. And there's a name. I think it's called Hotel Elite in Biel, in Bienne, in Switzerland. That's where they formed it. And then they realized that people can't say this, and they translated it to English, and it was ASIF. That's Association for the Study of Internal Fixation. That's what it meant, right? It's an association, Arbeitsgemeinschaft, and questions related to internal fixation. So why did this actually happen? Because at this time, trauma or fractures was completely haywire. People were doing whatever they wanted. There were funny plates which used to fail, nails which used to fail, wiring, and there were plasters, etc. And this group got together. And one may ask, why Switzerland? There is so much, why Switzerland of all the places in the world? And the answer is right outside here. The answer is skiing accidents. So they had a large number of trauma because of skiing accident, and they said we need to fix this. And there are 13 founding members, and you can see their photos everywhere. But Maurice Müller, Schneider, Villenegger, Algova, these are the famous names. Like if any of you did orthopedics before joining, you would know these people. And so they formed this, they had a meeting and they said, let's form a group, let's study all of this. And that's how the group actually came. And then the next thing they said is that let us do courses. So the first course was in 1960. And it was held in Davos. And this place, I think, was a tubercle sanatorium, which then they later took over. And I'll tell you about the Davos course as to what, how that went through. But some dates for you. 58 was when it was founded. 60 was the Davos lab. In 72, they went proper as an organization. They formed the AO International, which then became the foundation, which is like a charitable foundation with all the rules and a charter. And then this is the AO Center, which came up, and they're building another bigger one now, right? So what they decided is that there were no rules for trauma, and they said that we will now make our trauma based on this. Anatomic reconstruction, so that everything is perfect, especially for joints. Absolute stability. So this is what they thought at that time. Absolute stability, soft tissue respect, and early function. So this was the exact opposite when they had not proper stability and they used to keep the patients in bed for long. They used to get stiffness, fracture disease, and all of that. So from this, they went into, that was the first principle. See, those principles keep changing. There is nothing like a principle which stays forever. The thing is that here, what happened is, now comes the fun part as to what happened. So they collaborated with the industry, right? Obviously, you cannot be standalone just as a group unless you have somebody to manufacture those implants. And the first person who did that was Rob Mathis. So they started with this industry, which was initially Rob Mathis. And this went through a lot of, if I can just jump the gun, it went through a lot of changes. So there was Rob Mathis, then there was Stratec, and there were a lot of these surgical instruments, which now is DPS. So they are the industrial partner for this because the money has to come. But so how does it work? Why would they give money for free? And here also is an interesting story. So these surgeons were very clever. They devised implants and instruments, and somebody had to manufacture them, right? So obviously the industry has to manufacture them. Everywhere else in the world, when a surgeon devises anything, he gets a royalty, right? So I had gone to visit Jürgen Harms in Germany, and he was telling me, yeah, every time I put a screw, I get €2. So it's like, anytime, anywhere in the world puts a screw, I get €2. So what these guys did, they were altruistic. They didn't take that, right? That money went into the AO Foundation. So they didn't take a personal thing. So there was the AO Technical Commission. They made these implants, and that's how this funding, where do you think this building comes from? Who pays for our dinner? It's all because of that. So that's what happened. And you could not do these unless you attended these courses. And these courses were in Davos. In '84, they actually made a foundation, and then they built this center, which you're seeing. Where this center had 4 pillars: research, development, and quality. And this is AOASF. So we've gone through this, so let's not get into that. But the foundation had then 4 things as well. So it was education, documentation, research, and development. So that's what it works. So education are the courses, documentation is everything you do, development is newer implants, which are, you go on refining them, and obviously research. So one fun fact about the Davos courses, before many years, when I was maybe younger than a youth, Davos courses were more of fun. So people, I'm not saying they're not fun now, but a Davos course was 7 to 9 lectures, 9 to 2 skiing, 2 to 4 lectures, and 5 onwards partying. So that was a Davos course. But now, unfortunately, everything has changed. Everything has become more professional. So it's the whole day course. But what about spine? Like, I'm just talking about AO. But by the 1990s, what happened? The spine surgeons started feeling left out. So some of them said that we also need to join with AO. And there was John Webb, Max Abbey, and Paul Pavlov. So John Webb is from Nottingham, UK, those who know him. Max Abbey is from Switzerland. And they formed initially an AO specialty board. So it was not AO spine, it was just one group of AO. And these are the founders. So that Max Abbey is like very famous from Switzerland. John Webb, I mean, I knew most of these guys personally. Mike Jansen, with some of you may have met him because he was one of the past presidents. And that formed AO spine for the first time. And they followed exactly the same principles. So there was the AO USS, there was the AO cervical plate. All of these were devised by these guys. And they didn't take royalties or commissions. The money went into the foundation for research and education. And these are all the chairpersons. The first one was Webb and Abbey. And right now, if you know, it's gone to sort of South America. So Juan Emmerich is the one who's now. And before that, there was Astrubal. And before that, it was actually in India. Raj Shekharan from India was the chairperson. And this AO Spine International has really branched out because now there are AO spines all over the world. So I come from ASAP, that is Asia Pacific, but there is Latin America, there is North America, there's European, there's one more, that's MENA, that's Middle East and North Africa. So these are the structures, and then, so you have all these various regional chairs, and then you have various commissions, right? And these commissions, then it's like any government, right? You have the various regional ones, and then you have these various technical commissions, etc. So how did this evolve? So I'm just going to take you to 3 eras. The first one was in this, from 1990 to 2010, they were just finding their feet, doing courses, doing research, etc. But 2010 onwards, they became very serious. So they started with the AO spine classification systems, which, if you know, like I had a talk on this yesterday. If you have done trauma and you know ABC, they have beautifully transformed that into spine. It wasn't easy, but they have followed the same thing as in spine. And they made the thoracolumbar classification system, subaxial spines, sacral, etc. And then there were these knowledge fora, which were there. So there was a knowledge forum on trauma, tumor, deformity. So they gathered all the material, they came up with their guidelines, etc. What about now? Now suddenly, after 2020, AO has realized that everything, and thanks to the youth, everything is now digital. It's data driven. So they've really moved hugely to AI tools, digital learning, VR simulation. So before this, it was all courses, there were hands-on courses, and there were these models. And I don't know whether any of you have seen them, but they're the thin bone, which is almost synonymous with AO spine. And on this thin bone, the various workshops were held. And these were always sponsored by the industrial partner. But now you realize that you can't disseminate knowledge that much, and thin bone, etc. is very expensive. So now there is simulation, AI, virtual learning, and all of that. And of course, now they've moved into endoscopic and MIS where everybody goes. So now it's become huge. And now the core principles for AO spine are these, which you should know, which is accurate diagnosis, in which AO spine classification systems, which all of you have to know. But if you don't know, you get them as pocket cards. So it's very easy. stable fixation as well. So you need stability and preservation of soft tissue and alignment restoration. So we talk of the spine alignment, that the sagittal balances, lordosis, etc., all of that, and early mobilization. So these are the sort of principles on which AO spine is. And like I said, there are these technical commissions which, it's self-explanatory. I don't want to go into the details. And then there are these knowledge fora, which again, they have one chairman of the knowledge forum. And then there is trauma, degenerative, deformity, etc. So they study this, they look at the research, they come up with guidelines, and they give tips for further development. The other one is the classification group, and you need to know all these classifications. And last but not the least is you guys. And this is something which is, I think, your baby and your brainchild. And, I think I have not seen anything like this anywhere. And I was just telling Tarani and all that you all have got a huge jump. Actually, the middle generation is lost out. Because for us, we had to go through youth and middle and then became seniors. And then sort of I became faculty, chairperson, then, trustee and all of that. But you guys have just jumped it. You have caught the eye of AO straight away. And that's great. And, for you all, sort of the sky's the limit. And of course, for you all, there is fellowships, there is mentorships, there are courses, there is research awards, and you can contribute to the journal. And there is now the diploma, which was Raj Shekharan's brainchild, where you have a global diploma. So for the first time, what happens is every country has their own exam, everyone has their own qualification, but there was nothing which spanned across. So there is this AO diploma, which has a curriculum and training, which can really help people, especially if you are in a country which doesn't have its own formalized education. So the future is that, what is the difference between, because you may ask, there is also NAS, there is SRS, and we've got the Association of Spine Surgeons of India, and there's Eurospine. So where does AO spine come in all of this? I think AO spine is unifying. It is across the entire world, as you've seen. It's one thing which is across the entire world, which unifies research, education, innovation, and patient care. So this brings me to the second part of my talk, which I sneaked in, which is my favorite topic, as Tarini knows. And that's the history of spinal instrumentation. I find it very fascinating. I find everything fascinating. Like, I just want to know why has something come? And since we do spine surgery, I think we need to know where it comes, because only then, do you know where you can take it. So in the past, the two diseases of the spine which took the world, and when I say in the past, I mean pre-1900s, it's Pott's spine or TB infection, which I'm sure you in the West may not even see one case in your life, or may now, because of sort of immigrants and because of HIV/AIDS. But TB spine was the largest. So there was TB was rampant, and there was TB spine with paraplegia, with deformities, etc. And the other thing was polio and the deformities. And there was actually nothing to do for them. And so the first even attempt of doing a surgery was in 1889, where Hadra decided to use some wires and there were bars. But again, this was all completely, haywire. There was nothing which is fixed. And then the first person who actually came up with something was Paul Harrington. So in the US, there were 5 spine centers at that time. And Paul Harrington was at Texas. And we owe this man a great, because whatever we do today is based on what he started. And his first thing was very simple. It was just because obviously you can't have a complex idea first, right? You have a simple idea which you build upon. And he just had these 2 hooks, one below, one above, and this rod. And this was such a lovely design which nobody has been able to, the ratchet on top. So on that ratchet, it can only go in one direction. So once you put one hook below and the other one on top, and you distract, like your cogwheel train. Has anyone gone on a cogwheel train up one of the mountains here? It can only go one way. So you distract, it goes click, 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 and it's distracted. So there's a distractor on the top. Very simplistic, but at a time when there was nothing, it was so innovative. And what did he do? So before this, what was happening? Patients with deformities were getting plasters, and they realized that you have to do fusions. So they used to give plasters, and they used to make windows and put bone graft, and these patients used to be for years in the bed, right? And Harrington had these polio kids, and they kept collapsing in the cast. In spite of cast, you are not able to control them. So then he said, I have to do something to fix them internally. And he built this literally in his garage workshop, right? And he made it for aircraft grade steel. And he just got these in his pocket. So there's a completely different era. There was no regulation. There was nothing. You could do whatever you wanted. He got the rods in his pocket, and then he modified. So what he did, every time he did a case, he realized what is wrong and he modified it. So he kept modifying it and he was building them himself. You understand? There was no company, there was no DPS, there was no Medtronic, nothing. And there were 72 modifications before he finally came up with this sort of a thing, which is these Harrington rods. Hook below, hook above, and ratcheted rod on top. Obviously, it had drawbacks. I mean, we all would know this. So that's how it is. That's how the distractor works. So first thing is you're using distraction as the sole tool. So we know now that a lot of distraction is dangerous. And if you're very strong, then you can, because has anyone seen a Harrington rod in their life? You have, yeah. So I have done many because I'm like 25 years old in spine. So that distraction is you can just go click, 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 just go there. And we didn't have neuro monitoring in those days. So very often with that patient is to wake up paraplegic because you're just going on distracting, right? And it was a very powerful distraction force. So of course we had wake up tests and we had other things. And then we had these sayings that the patient is never grateful for the last click. So when you're doing click, click, click and you say, I want to do one more. And that's the one which causes the paraplegia. And there was no way of knowing it. So anyway, so distraction as the sole tool. The other thing is when you distract, so they were only looking at AP X-rays, right? They were not looking at laterals because the concept of sagittal balance wasn't there. So they had flat back syndrome. And because it was only one hook above and below, the hooks can just cut out and the rod can break. So the problem was at the junction of the ratchet and the rod, right? So that is where it is the weakest spot. So it used to break over there. And then you had to give casts and brace to these patients post-operatively. So this is lumbar flat back. So if you have a lumbar flat back, I think we all know this now. And the other thing is there was only one hook at either end, which could cut out or it used to break. So it breaks at the junction of the ratchet and the thing. So then what they decided, so when they first found out that you need to give a contour to it, he started using contoured rods. But what will happen? Of course, you have not seen a Harrington hook, but the Harrington hook had a round bottom. So obviously it will turn, it used to rotate. So Mo made the square-ended hook. So he made the square. So then it couldn't rotate. So then they got some sagittal balance. And then the pedicle hook, the upper hook was initially just in the lamina, but then they said, no, we can hit it against the pedicle. So Leatherman created a bifid hook which went against the pedicle. So everyone went on modifying this, and this happened in the United States. But cut down to another country, which is Mexico. And here's where it gets interesting. So in this system, what you had to do is obviously they realized, like Harrington realized, that you need to fuse, right? Initially, they used to just put the rods, and then obviously they used to break, and the patient used to go back. You need to fuse. So therefore, you need to give a cast. But what happened in Mexico? So this is Eduardo Luque, who is, in the 70s, he tried to do this. But the problem in Mexico was that it is very hot, as you would know. It's like one of the Indian countries. So one, it is hot, so it is very difficult for them to maintain casting or even bracing. And also they had huge distance. It's a huge country. And these patients could not come back for the casts. So again, he had failure. So he said, I have to do something better. And so he came up with segmental fixation. Simple. It is the need which formed, which got the research. And then he had this. So what he did is, he's very lucky that his name is Luque, and he made these two L rods. So he had these two L-shaped rods, and he put these sublaminar wires, and then connected the two to make it into a rectangle. So these were known as the L rods or the Luque rods. And so that was something which was completely new. And then when it came to North America, again, it was, wow, what is this? And he used to, like I said, there was no FDA, there were no implants, there was no Medtronic, no DPS. So he used to make the rods by hand, he used to bend them, and he used to even bend them on his knees. So these were the stories which were told about him, right? So we still use these wires. So people thought that these wires were dangerous. So I do a lot of these wires, which are sublaminar wires, because they have their own advantages. And it could then be combined with the Harrington rod. So you could get distraction, and with these wires you could get translation, which is transverse traction. So just to give you, I don't want to teach scoliosis here, but just to give you a simple biomechanical message. If two things, suppose something is very curved, and you do this, it will correct, right? But if it is less curved, if you do this, the amount of force required is much more. Are you getting what I'm saying? And the cutoff is 53 degrees. So if your curve is more than 53 degrees, distraction works. If it's less than 53 degrees, you are doing too much distraction to get less correction. But at this point, what they do is you use transverse traction, which is pull it this way. transverse traction. So that is what these wires did. And then they came up with this concept of Harry-Lukey. That's Harrington with Lukey, which in the US was known as Tex-Mex, and in UK was known as, it was known as the Leeds procedure, because there was someone in Leeds who was doing it. And just to show you one of the cases, and it makes it much cheaper. So this is my case, of course, 20 years ago, and very bad scoliosis, and you would immediately start saying, 30 pedicle screws and blah, blah, blah. But what I did is just one hook above, one hook below, and these wires. And I mean, cosmetically, I don't think, with your 30 screws, you're going to get much better than this, right? So that worked. So some other things, because I didn't get photos here. So people in the US, once these wires came there, they said, oh, this is too dangerous, because you have to make fenestrations and put it, and the cord was right there, right? And these were big American ham-handed orthopedic surgeons, 6.5 feet with huge hands. So you can imagine them pushing wires and getting paraplegias. So there was a guy called Dennis Drummond. What he did is, he put wires through the spinous process, right? So he had a Drummond button, and he put it to the spinous process and connected that to the rod. So it was not as good as Lukey, but still it worked. And like Tex-Mex, and somebody laughed, this was known as the chicken operation. So it was chicken wiring. So people who are scared to put sublaminar wires were doing that. So that's about these. And let's go to one more thing which we use a lot, which is the pedicle screw. So let's just get some very important names, because you may be asked. Of course, I can never be your examiner, but if I am, that's always asked. So the first use of a pedicle screw was by Boucher. Harrington, surprisingly, also tried to put pedicle screws, but King was the first one who described it in 1944. And it was not truly a pedicle screw, but it was a very short screw in the bottom of the pedicle. But Roy Camille is the first one. So Roy Camille is from France. He's the first one in the 60s who really put in a pedicle screw. And after that, there was Art Steffi, who you should know again, because he had the VSP plate, which I'll show you in a minute. And since we are here, it's important to know about Magel, who did the fixator extern, which I'm going to show you, and then Dick, who internalized it. So I'm going to come to that. So this Professor Raymond Roy Camille, he again studied spinal fractures, and he said, why not fix the pedicle? And people called it dangerous, because when you look, see, now you're used to seeing it, right? But in the past, if you're not, and you look at an X-ray, it looks as if somebody's put screws to the spinal cord. And people called him dangerous and mad, and he used to make the screws himself in a machine shop. And over a time, can you see the last one? He went to the Paris morgue at night to put these screws in. And that's how he developed it. And people asked him, don't you think the pedicle screw is dangerous? He said it's only dangerous when a surgeon doesn't know where the pedicle is. And that answer is there today as well, right? So obviously it's 100% safe, but if you don't know how to put it, you're in trouble. And that's Roy Camille. So the only thing is that everything develops in steps. It's never directly. So because he had the trauma plates, the round hole plates. So he used to put the screw through these plates, which obviously, as even you can know, it's going to be a big problem as to how to align, right? Then he made nests, how to align. And the second thing is something known as a claw hammer effect, which I didn't get a diagram. So a claw hammer effect means what? If you have a plate and you have screws which fix the plate to the bone, right? If there is any back out, that plate causes the screw to come out, right? So because you are using the force of the screw to fix the plate. So what happened? Arthur Steffi, he came up with this, which is this VSP screw. So this was a beautiful. Has anyone used a Steffi screw and plate? No. So I must have done around 200 or 300 of these. Like I said, I'm 25 years old in spine. So this Steffi plate was the thing which we had. So it has a base plate. One second. Yeah. So it's got a base plate, right? This base plate, and then it's got two nuts on top. And the plate is sandwiched between the base plate and the upper nuts. So your fixation is not based on the screw. The screw is inside and it has base plates, and then you put a plate and you sandwich it. So that's how it was used. So it had nests like this, because obviously the pedicles are different in different patients. So you could, for the first time, independently put screws and then put a plate on top and sandwich it. So obviously, but it was very bulky. So this is known as the variable screw placement, or the VSP. And this is Art Steffi. And again, what happened differently were these longitudinal members, which initially were the simple plates, and then the VSP plates, but these VSP plates were very bulky. And plus you can imagine, you can give lordosis and kyphosis, but you can't give a lateral tilt. These are very thick plates, very thick plates. And then people came up with these screw rod systems, which all of you use now. And the first system actually came with this innie and outie. Has anybody seen this kind of a system? Yeah, so this is the innie and the outie. This was by Jürgen Harms in Germany. And this was the Moss system, was a modular something in spine. And why they had an innie and outie was because if they had only an outie in those days, right, if they had only an innie, the flower used to open up and the rod was loose. And if they used only an outie, again, it used to be loose. So he had this innie and outie, which sort of compressed against each other. But of course, over the years, metallurgy got better, machining got better, engineering got better, and now we only use innies. Right? This is something which I said I'm going to talk to you about. And this is almost like, I couldn't get one of the actual patient pictures, but they must be somewhere around here. So Magel's external fixator. So what happened is that they thought, how do we treat backache? And they said that we can do fusion with backache. So how do we know? Because even 77, no MRIs, right? How do you know? So what they used to do is, they used to put in these external fixator shank pins into patients. So L3, L4, L5, and then he used to put this external fixator outside the skin. And then he used to tighten various things and make them walk. So first L4, 5 is tightened and you make them walk, and L3, 4 is loose. And if this is my pain is better, then fuse L4, 5. So this is the external fixator. Funny, but well, there it was. And then they internalized it and they made it the internal fixator. So then when AO came in, of course, the Swiss engineering principles and the discipline and all it came through. And then everything started getting standardized, right? And they, you had perfectly machined screws, so there was nothing which was left to chance. And the systems were much more reliable. Cut to Cottrell and Dubosset in 1980. So they again had a very, very wild or a completely different idea. Because so far, for scoliosis, etc., it was just, you're looking only at the coronal plane, right? But for the first time, they said that, okay, it is a three-dimensional deformity. Scoliosis, we know this now. But you can imagine at a time when they didn't know this. We were only looking at AP X-rays. So they said it's three-dimensional. There's a rotation element. There is at various segments. So what do we do about it? And they said that we do put segmental fixation. And they came up with this concept of rod rotation or rod derotation. And then they said, let's get all these implants together. Let's get everything together. And then they had these kind of hooks which went against the pedicle. And they had these smaller hooks which went against the transverse process, which went into the lamina and pedicle screws. So for the first time, you had like a cafeteria in front of you where you could use screws, hooks, rods, and even I used to use even wires. And you can really build up your constructs without much. And this is again one of my early cases, maybe 15 or 20 years old. And you can see using these principles, 2 rods, cross links, hooks on top, screws below, and wires in the middle as well. Don't miss the wires. So right at a time when it was difficult to put screws in the concavity, we used wires. Then we came to titanium and polyaxial screws because the issue was MRI compatibility. Once you put all of these, which was stainless steel, you couldn't see anything. Then titanium came, and a lot of, that's when it suddenly took off. So the implant thing just took off after the 90s and it went ahead. Another interesting topic, my last one in case you're bored, is on the interbody fusion. So this is an interesting story. The guy with the hair is me. And the other gentleman is Ralph Cloward. So Ralph Cloward devised the PLIF, right? And with another guy called Lin, who was in France. So why did he devise the PLIF? That's a very interesting story. So Ralph Cloward was a neurosurgeon. And he was practicing in the United States. And he had some kind of lawsuit against him. So he had to run away. And he moved to Honolulu, Hawaii. What happened over there is, obviously spine becomes a big thing. He said that he was the only one there to make the problem with discectomy was recurrence. So he said that no, my discectomy should not recur. And that's why he came up with this idea of the PLIF, where he used to put bone graft into that. The only thing is, of course, it's evolution. So he used to do that, but he used to not put screws because they were not there. And often there were problems with the rods backing out. And Art Steffi, who I showed you earlier, he's the first one who did the screws along with the PLIF, which is then the forerunner for the next operation, which is the TLIF, which was devised by this gentleman, who is Jürgen Harms from Germany. So TLIF, for the first time, he thought that why go? Because the problem with the PLIF was that you kept retracting the dura, and these patients had either deficits like a foot drop or they had radicular pains. So he said that we don't need to go there. We can just go laterally and put cages. And what he did, it seems that he was sitting and drinking coffee and was wondering, how can the cage be made strong? What is a good cage? And he actually saw this picket fence outside his house. And that's how he made this cage, which is known as the moss cage. So these initial cages were like these moss cages, which were then, because he saw people coming, it was very strong. At the same time, it could be cut with pliers and made smaller. So he said, oh, that's what I need in the operation theatre. And that's how he made these moss cages. Which brings me to another very interesting tidbit about cages. Okay, I know you know. And this is a very interesting story. So the first interbody cage was known as the BAK cage. Okay, BAK is Bagby and Kuslich. And, the slide's already come up. Sorry about that. So Kuslich is a spine surgeon, but Bagby was a vet. So where the hell did a vet come into? So how did this happen? So it's an interesting story. I didn't get the slides, but so in the US, there is the Kentucky Derby, which is very, very famous. And there was a 3-time winner of that Kentucky Derby. And that horse's name was Seattle Slew, right? So I'm not crazy because this is a great story. So Seattle Slew was the 3-time winner of the Kentucky Derby. He got something known as wobbler syndrome. Wobbler syndrome is cervical myelopathy, which we know now. So, osteophytes and cord compression, wobbler. So he couldn't walk, right? He was myelopathic. So this George Bagby operated him. He said, how to operate? Because you have to do an ACDF in a horse. And he devised this, right? Which is known as the Bagby basket. So he did this ACDF for this horse. And he put these things which are the Bagby basket, right? Then what happens? This guy goes back and wins the Kentucky Derby again, which again is huge. So after that, there was in the US, there is the Today Show, or one of the very famous shows, on which there was a 1-hour program on this. And this was seen by Kuslich, who was a spine surgeon, who contacted him, and then they devised this BAK cage. So, that's good. So I find it very fascinating to share this with you all. And hopefully one day, when you all are my age, you all are called by the Youth Forum, you all will have more stories to tell. MIS, of course, is the new thing, which is Kevin Foley from the United States thought of it. It seems he too was watching a TV program on laparoscopic cholecystectomy, and he said that why can't we do MIS? So he started doing telescopes and endoscopes and all of that. And we all do MIS now, so there's nothing new in this. And then what's the future now? Navigation and robotics. Again, a lot of what we do comes from the airline industry, including checklists, including titanium. So airline industry and surgical field has a lot in common. But these same navigation and HUDs, etc., are the ones which fascinated people to get into all of this. And now the next future is 3D printing and patient specific. So now you can 3D print, you can actually make an implant exactly to the specification of the patient, and that's what it is. So you can do it for tumors, tumor reconstructions, and for deformities. So, the future is huge. I think this same talk after 20 years may take 3 days, but hopefully I've been able to finish in time. Thank you. Thank you. Any questions? And you should thank Tarini, because every time we operate, I just say, who put the first pedicle screw? I don't know. Get out. So, read and come. And my biggest enemy now is ChatGPT, because I have got 5 fellows, right? And 3 of them are scrubbed with me. And I ask these questions and one guy says, ChatGPT. But anyway, you all needed to know this. Okay? Thank you. Thank you. Thank you.